Good morning, everybody, and good morning to all of those that are watching through the computer and webcast as well. So welcome to this morning on righting wrongs using health delivery science. And we have here Sanjay, Pradhan, and Tamar. And I will pass to Sanjay, who would like to open this meeting. Sanjay.
Good morning, everyone. Pleasure to see all of you. I want to very warmly welcome Dr. Al Mulley and Jaime Bayona and the entire delegation from Dartmouth Center for Healthcare Delivery Science. Really very warm welcome to you for taking the time and coming and sharing your experience with us. This is, of course, really well timed for us. Ostensibly, this is well timed because President Jim Kim has talked quite passionately and persuasively about the science of delivery. I say ostensibly because it's not just because Jim is talking about it. The fact is, wherever he has spoken about it, in whichever country he has spoken about it, this issue of delivery science is resonating very powerfully with our country clients. And why is that? That's because every country, certainly most of the developing countries I know, there is a big disconnect between policy formulation and policy declaration and implementation. And that disconnect is at the root of problems of legitimacy, as big as legitimacy of the state or credibility with which public services are delivered. This is a big issue for us in the World Bank, because if you think about it, we have traditionally financed and supported government programs, and we posit away implementation. We go back and look at it later. Not in all cases. I'm dramatizing to make a point. But the issue of implementation has really plagued us because you have very different degrees of implementation progress that we see. And so for us to understand in greater depth how we can tackle this problem of delivery is going to be extremely helpful. So we've had the privilege of working with the team for a little time now, and we look forward to deepening our collaboration. You have taken a very complex issue of healthcare delivery in the U.S. And other places where there are very differential outcomes for different types of expenditures, and you've really developed an evidence-based innovative solution to tackling or approaches to tackling this issue. What will be very useful for us to learn from this experience, and also to start for all of us colleagues here and lots of people online to start to think about how we may apply this to the work of the World Bank Group and in different types of services, different types of sectors, and different types of challenges. Just to give you one quick example, and I'll close with this because I want to hear from our Dartmouth team. If you just take a look at one issue that we are wrestling with in the World Bank Institute, which is the delivery of essential services to, let's say, the needy patients, and we find that there are lots of failures in the delivery of services, essential drugs to needy patients in many of our countries. We finance things a lot, but the delivery is really broken. And there's a whole chain of things that can go wrong. It can be corruption in the procurement or collusion in the procurement of services. It can be outright theft. My colleague Ed Campos and I had looked at this actually at a value chain of delivery and where the leakages occur. You can have leakages in the outright theft in the warehouses, or you can have problems in the delivery of drugs to important constituency groups, if you will, rather than the needy. And then you have all the way down to the last mile delivery to the actual patient. And this is a very contextual adaptive issue. It doesn't lend itself to an easy technical issue. But the very fact that in the Dartmouth approach, you've managed to think about this very contextual issue of doctor-patient relationship and how to actually tackle that relationship and address problems at that level could be very useful for a large number of other such problems and issues that we face. So there are lots of parallels, and we look forward to learning from you. I must say that we've been really fortunate to collaborate with the Dartmouth team on the Salzburg seminar on the rights-based approach to healthcare, and we look forward to deepening our collaboration. A strong partnership is developing. So without further ado, I want to first pass it over to Tamar, but also thank Tamar and our HDN network for very good partnership in this area and pulling this together.
Great. Thank you, Sanjay. It's a real pleasure to be here today and to see some of you who I suppose I saw over the video conference, so you weren't terribly visible, in person here. It was a pleasure to participate in that global symposium in Salzburg from afar. And I'm very happy to kick off this event together with Sanjay. And Sanjay, let me reciprocate the appreciation. Thank you very much for your continued partnership on this important issue, and in particular, special thanks to Maria Luisa. So on behalf of the Human Development Network family here in the World Bank, a special welcome, a warm welcome to our guests, Dr. Mulley and Dr. Bayona. Thank you for joining us today. We are really looking forward to learning from you and your experiences in incorporating evidence and scientific methodology into service delivery. I believe a focus on the science of delivery is an essential complement to embracing a rights-based approach to health and other services. I think the two have to go hand in hand. And today's conversation couldn't come at a better time for the health community in the bank. Just last week, Margaret Chan and I co-convened a meeting in Geneva that brought together ministers of health and finance from a large number of countries around the world to discuss universal health coverage, an aspiration, a goal that I believe embodies both of those ideas, science and rights, effectively. And the idea is simple and compelling, though not easy to implement, that everyone deserves access to quality, affordable health care, that no one should have to choose between the health care they need and feeding their families, that no one should fall into poverty due to illness, that we should all have the opportunity to lead healthier, more productive lives, and that countries should aim to realize these aspirations in fiscally responsible and institutionally sustainable ways. Now, many countries have been implementing initiatives to improve health outcomes for their citizens and protect families from the impoverishing effects of illness, and some have done so to really good effect. By definition, we can't achieve universal health coverage if countries can't deliver the services that their citizens need and want. And if these services aren't available, or their quality is wanting, or a visit to a hospital or a clinic means less food on the table, access and utilization will, of course, fall short. At the same time, inefficiencies in social spending are rampant in many countries. We need to better understand how to reduce these inefficiencies in different settings, improve outcomes, collect evidence, and of course, correct based on the lessons that the data provide. So today I'm really eager to learn about delivery science and hear how the experiences of our colleagues in Dartmouth can enrich our work in the countries in which we work, generate better value for our investments, and ultimately improve health outcomes for people. So I want to just stop here and look forward to hearing from our guests. And thank you very much to everyone who's here and whoever is watching on the web stream for today's conversation. I'll be here for the first session, and then I'm afraid I'm going to have to leave, but I wish all of you a fruitful discussion.
Thank you very much, Tamar and Sanjay, for starting this conversation. And I think that you have put on the table the issues that we are going to be dealing with during the morning, and trying to understand also what we have been in our team trying to understand for the last 6 months, and discovering how delivery science had a lot to do with the work that we were doing on a rights-based approach to development and to healthcare. So this is going to be a conversation. So we're going to try to make it a little bit informal, although it doesn't look informal with this table. But we'll try to make it like that so we all learn. And I would like to ask our two panelists for our first conversation if they could come and move here so you can also be more comfortable. Thank you so much to HDN, and thanks, Sanjay, for all the support in WBI. All right. Thank you very much. So, as I said, let's start with an informal conversation, and let me start telling you a little bit why are we here and how did this happen. And you heard from Sanjay and Tamar a lot about Salzburg, and but they didn't explain what was this. So if people don't know, I will just try to explain a little bit how the history of this joint effort started, which actually was almost by coincidence. So we were working, as you said, on the rights-based approach to healthcare, and because Leonardo Cubillos, who is here, and let me in a second, I will introduce both of them, was invited to the Salzburg seminar in 2010 to be one of the fellows. This is a place where multiple stakeholders from all over the world are brought together to discuss not only health. These are seminars in many different topics that are of importance for global economy and so on. So right there, something happened. They were having some wine or something, and then they learned about our work on rights, and they were very interested. And then later in 2011, they suggested, why don't we work together and put together a global Salzburg seminar on the right to health and health systems. So that's how we started. And then in 2012, they introduced us to Dr. Al Mulley. And when we learned a little bit of what he was doing, then we also realized, and he realized, oh, maybe we should be, we have something in common to learn from each other, and he co-sponsored also the Salzburg seminar, and we started working together. Since then, we wanted to learn much more, and we wanted to learn of what they are doing in the center, and that's why we are here, and we want to share that knowledge with all of you and also hear all your questions. So let's start with Dr. Al Mulley. So you know, probably you already have the bios as well, but Al is the director of the Dartmouth Center for Healthcare Delivery Science since November of 2010. And before, he was the Chief of General Medicine and the Director of Medical Practice Evaluation Center at the Massachusetts General Hospital in Boston. And he was a Professor of Health Policy in the Medical School at Harvard. So he had been working a lot in research on decision theory and outcomes research to distinguish unwarranted and warranted clinical practice. So we'll learn a little bit about that. So Al, you heard from Tamar and from Sanjay that we are talking a lot about in the bank about delivery science. But really, I hear so many different definitions and understanding that I want to hear and for everybody to share your understanding. So what can you explain to us what delivery science is and what is it like to achieve?
Maria Luisa, thank you for the introduction. Thank you, Sanjay, Tamar. It's good to be here. Let me just say at the outset that if you're expecting a precise definition of delivery science, I'm afraid I'm going to have to disappoint you. Delivery science was a term used for the first time in academic medical centers and universities, to my knowledge, just about 2.5 years ago, when the Center for Delivery Science was established at Dartmouth. And when that center was established, the goals were clear. The goals were essentially what Sanjay and Tamar cited as the need to create social value by executing very effectively in implementation, in innovation, and in improvement. There are lots of questions about why that didn't happen, and there was an underlying assumption that what we needed to do was to break down silos. We needed to draw from across disciplines. We started talking about the need to bring the best thinkers together from across disciplines and then intentionally and iteratively connect them with the best doers across context. And that context was really important because this was going to be a science about how to implement, how to improve service delivery in complex adaptive systems. And some of the things that we wanted to measure, because they're the most important things, are going to be difficult to measure. And often context it contributes to that difficulty in measurement. So from the very beginning, we saw the purpose of delivery science as creating partnerships, creating collaborations, bringing together the research agenda, which is often, unfortunately, too disconnected from the operations agenda. And in fact, one of the goals of delivery science is to have the research agenda driven by the operations agenda, to move from research being something that is done here and then disseminated to practitioners being the ones who have us something to teach about how to do things effectively, what works for whom, what's valued by whom. So let me just say that there's nothing, there's no disappointment that you're hearing from me about not being able to define it precisely. It has taken a long time for other fields. Think about when molecular biology was a new term, right? It had been biology before that. We have a lot to learn together in collaboration in order to provide a more precise definition for this. In the meantime, we should look at it as something under construction and something open to lots of different disciplines to help define.
Thank you very much. But I still like to know, like, why do we need delivery science? And in the context of development, what does this mean? What does it mean to talk about delivery science?
Well, I think we need delivery science because we know an awful lot about what we want to do. We don't know enough about how to do it in different settings defined by different levels of resources, different settings defined by different cultures, and those cultures may be within organizations, they may be within nations. So we need to recognize the importance of bringing the same kind of discipline that's brought to what everybody would agree in the university setting to be science to these much more complex tasks. We need it in part because the discipline of the commercial sector, driven by something that's really easy to measure, like financial return, and the discipline when you can really easily measure in the laboratory, or even in some clinical settings, that ability to measure what matters in that paper allows you to bring discipline to the execution. We need to recognize that we need to find measures that may not be perfect that bring the same discipline if we're going to create social value. I think it's as important in development work as it is in developing countries, and a lot of what motivated Dartmouth to step into this field is 30 years of work in trying to understand one area of execution against social goals where the United States has done very, very poorly despite all of its wealth, and that's healthcare. There are two strands of the research at Dartmouth that I think are highly relevant to development work in healthcare and in education and in other areas. And it's all related to being able to measure the social value. One of those areas actually began when a colleague left Johns Hopkins to travel to Vermont to do some research to support his advocacy for more healthcare resources for poor people who lived in northern Vermont. That sounds very much like a development task. He went there, and in order to develop an epidemiology of healthcare so he could prove the deficiency of the available resources, he developed ways of identifying hospital market areas and looking at the inputs and looking at the outputs. And instead of finding a strong relationship between inputs and expenditures and outputs, he found that geography was destiny, that the care that people received depended more on where they lived and who they saw rather than who they were and what they cared about as individuals. And he took that work and extended it across the entire United States, creating over 3,000 hospital market areas, coalescing them into 306 hospital referral regions, and discovered in that work that there's very little relationship in the United States between the threefold differences in per capita expenditures and the health outcomes. It implies an enormous amount of weight. We spend 3 times as much on Medicare beneficiaries in Miami than we do in Minneapolis. We spend more than twice as much in McAllen, Texas. Some of you may have heard that story from Atul Gawande than we do in El Paso. Very similar demographics, very similar educational level and social economic statuses in those 2 communities. And when you work really hard to measure the outcomes, because it's hard to do so, the people in the high expenditure areas do no better and perhaps worse. Higher mortality, less satisfaction with the service. Doctors feel less gratified with the service they're providing because it's so frenetic and not producing value for patients. So that's one strand of the research, and we can talk more about that later because some of the responses to that, the Dartmouth responses to that, lead into the question of a rights-based approach. The other strand of work comes from borrowing from the management sciences and the engineering sciences to apply industrial quality management to process improvement. When Wenberg created these atlases, not only did he see dramatic variation in practices, rates of bypass surgery or stenting or various ways to treat diabetes, he also saw dramatic variation in outcomes. Mortality rates that ranged from 2% to 12% when you had the bypass operation. What Dartmouth did is they identified some industrial engineers who would follow patients through the different hospitals where the mortality rate ranged dramatically and make note of all of the processes of care. Where was the anesthesia screen? Where was the incision placed? How much communication was there between the anesthesiologist and the surgeon? And then they identified relationships between good outcomes and bad outcomes in the different processes. And over a relatively short period of time, they were able to reduce in northern New England the operative mortality rate from 6% to 2% on average and dramatically narrow the distribution. So you see, on one hand, there's this strand of work that asks the question, what's the right thing to do for somebody? If in the United States, the rate at which we do bypass surgery in the Medicare population ranges from 3 per thousand to 12 per thousand, how do we know we're making the right decision? What's the right rate? And if the mortality rate ranges from 2 to 12%, how do we know we're doing it right? So in many ways, delivery science and its impact, both in healthcare and in other areas, is all about getting into the processes of delivery and being sure that you're doing it right. But equally important, and this is where it connects to a rights-based approach, is be sure you're doing the right thing for the individual who's going to live with the consequences of the service that's delivered. There's no point in doing the wrong thing right if what you're trying to do is to produce social value that certainly includes more than the aggregate of individual value produced, but boy, that sure is a cornerstone of it, isn't it? Okay.
Thank you. There were so many things in this construct that now I'm confused.
Okay.
So I will.
You're probably not the only one, so thanks for acknowledging it.
I just want to understand something. So you were saying this is all about getting the best social value for what you invest, and you should be investing on the right thing. But you also talk about other different pieces that are starting to coming together. You talk about geography is destiny, and you talk about some maps where they saw things. Also, you talk about some groups of hospitals and therefore people getting together to do something to improve the outcomes. You mentioned something that we have in all the sectors in development, even within a country, all these huge differences in outcomes, and that's the problem we have with average indicators. All the time we will put an average indicator, and it doesn't mean much because the differences in provinces and districts in mortality rate, in school attendance, and etc. are huge. So can you explain again a little bit about the different pieces of this construct? I mean, what are the specific approaches that the delivery science emphasizes? And you already talked a little bit about that, but could you repeat?
Well, just to reiterate quickly the general, and then I'll come back to some of the specifics. We believe that delivery science, in order to be effective in allowing those with the very best of intentions to execute more effectively against those intentions to produce social value, is to leverage multidisciplinary expertise. That's probably the key. It's probably most critical to break down silos. And the purpose of that is to allow for continuous learning from those who are trying to do the implementation and who are seeing the successes and failures in different contexts. Some of the problems with thinking of research as over here and implementation and practice over here is how context-specific success can be. An intervention that works extremely well in one context can fail miserably in another. If you don't have a portfolio of contexts from which to learn, you can easily take this success and try to scale it, and perhaps do some harm in some regions. Right? Or you can take a failure and kill it, fail fast and move on, when in fact there's another context. So the notion of leveraging multiple disciplines, creating partnerships across contexts. Some of you know we established a master's degree program in healthcare delivery science. In the first 2 years, we've had people from 10 countries in the program, including China, including India, including Rwanda, Kosovo. And that's because we feel so strongly that we will learn, not only in help defining it, but we will learn about what works where by really emphasizing what can be learned in different contexts and what we can learn from what's done in low-resource contexts. As I said, also that's all about operational innovation and combining innovative approaches and strategies. It's about the 3 I's. It's about implementation, innovation, and continuous improvement. And knowing when to stop, being able to measure such that you can say this isn't working in this context. It may have worked there, it's not working here. Let's find something that works here and share that knowledge with those who have similar contextual variables and obstacles. It does demand rigorous evaluation. There's no question about that. When we had these early conversations about a definition of delivery science up at Dartmouth, no less than Francis Collins, the head of the NIH, listened very, very politely and then said, I'm not sure where the science is. Tell me where it is. And our response was, give us a couple of years, Francis, and come back and we'll tell you. And we're still working on that. We knew this was going to be something to be constructed. If Francis were here today, I would say to him, Francis, what did you do today that was science? And I would wait patiently. And if he started talking about the modern-day equivalent of cleaning the test tubes and being sure that the analytic devices were giving him the right measures, I'd say, come on, that's doing the dishes and making sure the hardware works. What would you do that was science? And eventually we would get to the point that it was about a discipline, right? It was about testing a hypothesis and gathering data with the intent to disconfirm what you hoped was true, and to use that to build theory. So that's the general thrust that I would like to leave you with. Going back to what might have been confusing, just to say it simply, Dartmouth has a history spread over 30 years of trying to map inputs and outputs and trying to understand the relationship between inputs and outputs, learning from variation in choices that are made to deliver one service as opposed to another in order to learn better what's of value to the individuals who receive it. But also this other strand, this process improvement strand, learning from the relationship between differences in processes and outcomes in order to be sure that you're effectively delivering. And there's another piece I want to add to that, but I'll come back later. I was looking at Sanjay and Tamar and the sort of the essential services list. There are things in healthcare for sure that we refer to as effective care that you want to be able to execute very, very well. And that's where the value chain, the supply chain, all of those issues that come from operations management, operations research are critical. But there are so many things in healthcare where they're supply sensitive. Whatever capacity you build, it will be used. So if the investment decisions in building one set of capacities as opposed to another to deliver one set of services as opposed to another aren't informed by healthcare delivery science that focuses on the value, you're going to end up building capacity that falls short of meeting needs, while it exceeds wants for the same individuals. And there's nothing to call that but waste. Right? So there are two kinds of waste here. There's the process efficient, the productivity waste, when we don't do things well. And then there's giving things to people that they wouldn't value if they just knew a little bit more about what the alternatives were. Is that better?
Yes, I think so. I will ask them if that is better. So how does the delivery science contribute to this, closing this gap between needs and wants and doing the right thing? And what is delivery science going to bring to the global health goals or agenda?
Well, to some extent, I just referred to waste on several occasions, and in our country, most people who understand the work at Dartmouth and view it, I think, objectively, would conclude that we waste somewhere between 20 to 40% of what we spend on healthcare in the United States, and most of us would think it's closer to 40. Margaret Chan, in the 2010 introduction to the World Health Report, used the 20 to 40 figure and applied it across the range of wealthy nations. And sometimes we all have in our mind the decreasing marginal return curve, and we see a steep slope, and then it flattens out, and then we're on the downward slope. But when you think about the $8,437 per capita that we spent in the U.S. on healthcare and wasting 20 to 40%, that was 2010. Or the $16 per capita in Eritrea. Given my limited understanding of healthcare research in those regions, there is no reason to believe that the waste is any less proportionately, right? There's no reason to believe that it isn't 20 to 40% in developing countries, given what we know about the quality when we examine it. So there's this profound question about inputs, outputs. What are you measuring? What are you trying to accomplish? How do you create the discipline to execute in creating social value and development? And everything I've just said, I think, applies to education and to other areas of development as well.
Very well. Just before we go to Leonardo, I am intrigued on why is it going on the way it's going in terms of in the United States, for example? What is the root or deep root of this problem of needs and wants becoming so spread?
Okay. And this is actually a very good segue to rights-based. Across the world, all of the stakeholders in healthcare, people who are ill or at risk of illness, health professionals who chose their vocation, their career, in order to be helpful in those situations, and policymakers who do their very best in order to provide access and bring those two parties together so they can produce value together. They all have reason to want desperately to believe that the highly trained professional will execute well in doing the right thing. Think about it. The health professionals certainly have a reason for all of society to think that, whether it's in the United States or in some other country. It's the source of their status, their income. Patients certainly have a reason to want to believe that. When you are vulnerable, more vulnerable than you ever felt in your life because you are ill, you want to be able to trust somebody. And you want to be able to trust them to do the right thing for you. And you may go to Google, but you really want to be able to trust the person who is caring for you, right? So you want them to know what the right thing to do is, and you want them to be able to execute it well. Right? And then policymakers, and we've seen this in the United States and we've seen it in other countries, and this is not unrelated to the negative unintended consequences of a rights-based approach in some countries. They want to be able to step back from any concern, public concern, about withholding moral entitlements. And one way to do that is to turn to science as giving you all the right science as it's narrowly defined, without all of the things that are difficult to measure about what individuals value. Right? Is to say science gives us the right answer. Now it's just a matter of
providing access. So I think that the deep-seated underlying problem with regard to healthcare delivery is everybody wants to believe there's no problem with choosing the right thing and executing well. And it's just about bringing resources together to provide structural quality elements and access to more care. And our big concern is that, for instance, with a rights-based approach, you don't want people to feel entitled to something that they wouldn't choose if they were well-informed or more engaged. In many ways, our take on healthcare delivery science is enough top-down from policymakers, enough top-down from scientists. You know, how do you have practitioners empowered to learn what the individuals who live with the consequences of the services value? So that's what guides investment, that's what guides policy.
Thank you. So it seems to me you're talking about shared decisions
Yes.
between policymakers and patients and doctors and so on, which brings to me a big word, participation. So I want to turn to Leonardo Cubillos, who is our senior health specialist in our group in WBI and has been working for quite a while on a rights-based approach. And I'd like to ask you if this idea of shared decision-making resonates with you in any way in the context of developing countries and precisely in the context of policy decisions for implementation and monitoring of these processes. Does it resonate, this idea of participation and shared decisions?
Thank you, Maria-Luisa. Good morning, everyone. The answer to that is definitely yes. Human rights, and particularly right to health, is also doing the right things, but doing the things right. And in that sense, participation is about, one of the things it's about is making sure that the services health systems choose to deliver and the services that they actually delivered are acceptable to the population. And acceptability of the services that are accessible to the population is a cornerstone pillar to health systems. Otherwise, you will not progress toward meaningful outcomes.
Thanks, but I have a preoccupation, yes. I think that that's a good idea, and it makes sense that people should participate on decisions and so on. But after the 2010 WHO report on universal health coverage and the idea of countries moving towards universal health coverage, and with the democratization of societies and people participating more on decisions and their care, it seems to me that there are now citizens that are demanding, rightly so, what they have been promised to receive and they are not receiving. But also there are citizens that are demanding what they would like to have but has never been promised to them. And this could be a risk for achieving universal health coverage in countries. So what do you think about this?
That's a tricky question, actually. I think that in different ways. One, you can think it about in terms of the quality of the healthcare that is actually delivered. You can think it also in terms of sustainability. And you could also think it from the point of view of accountability, of social accountability. And if citizens are demanding healthcare, either that is not included in the benefit plans, or if it's included, it's a certain type of participation, but more on the social accountability aspect to that. And it seems to me that having accountability norms and accountability processes in place is by all means of a stretch positive, very positive. I'm gonna quote Alan and Margaret Chen. 20 to 40% waste in resources speaks to us about a discrepancy between what is promised in the norm, the de jure provision, and what is actually accessed, the de facto provision. If we were to close that gap using different mechanisms of social accountability, just imagine how much we could accomplish. So that is absolutely fantastic if you use accountability to close that gap. Now there is also a reality that in different settings, patients are demanding newer and more expensive technologies, and sometimes technologies that are not proven, well, that's where the decision-making processes of reaching towards or achieving universal health coverage need to be improved by both governments and citizens as well. And it seems to me that the processes need to be improved in at least two areas. One is the evidence that is incorporated and how it is evaluated as well. But the other area is what processes, what reasonable processes, what participative processes, who sits on the table and who revises the decision and when. That is also need to be incorporated. And it seems also to me that some of the elements of delivery of science, the patient and physician relationship can also be applied to a broader level when, for example, I don't know, Australia or any health system makes a decision to provide a particular treatment to a subset of patients, and then needs to monitor that decision, but also needs to revise that decision. So, but to me, in addition to sustainability, achieving universal health coverage, these demands of population speak to social accountability, which is a very natural process that is not only taking place in health but elsewhere as well.
But then, when I think of developing countries that we have been working on, we would like for people to participate in decisions, and we would like to know what people need and what is what people want in order to give something closer to that. But how do we make people to participate in an effective way? Do you have any ideas on how could this happen? What kind of instruments or tools could be used for that?
There are many examples in developing countries and also in developed countries. Evidence is beginning to appear as of now of the impact of that participation and the social accountability as well. There are two ways to do it, in my mind at least. One is a top-down approach, and the other one is a bottom-up approach. Even if a government decides to not open up spaces of participation, bottom-up, they will come. They will appear. Example at hand is the Arab Spring. They will nonetheless appear. And from a top-down approach, there are very, very different mechanisms. One is litigation, for example, that is happening in Latin America, but in other contexts. And throughout the decision-making processes, we have different examples. NICE in UK, who created back in 2002 a Citizens Council to inform the overarching moral and ethical basis by which decisions were made, and of course there is a lot of controversy as to the functioning of the Citizen Council, and yes, it could be improved, but that is an example. PBAC in Australia has, just as you were mentioning, Al, they also have a multi-stakeholder kind of composition, which includes patients, and they have a mechanism to revisit the decisions and to assess whether that was a proper decision or a fair decision given their context or not. And one example that was very recently introduced to me actually this weekend by a colleague is not in the healthcare field, but and I was reading through it and I was mesmerized, is the National Taxpayer Association in Kenya. Has nothing to do with health, yet they're opening up spaces of participation by gathering data, presenting it in a systematized way, and informing the decision. There is still much discussion as to how much government uses that decision, but that is the second step. So I think there are many channels, and again, as in delivery science, this is not a finalized process. We are still learning by doing.
It seems to me that this is something that maybe we need to take into account when we are designing projects or operations to support countries moving towards universal health coverage and thinking of these processes. But you mentioned something that's connected to what Al was explaining. Even if citizens participate and so on, we need to learn if something is working or not working in place. And Al was referring to the analysis or the research of the differences in outcomes and in processes. But for that to happen in developing countries, that seems to me that there has to be perfect transparency of the information. do you think that this is something that needs to be there and be next to what the other principles that you were mentioning of participation, and to be able to hold accountable the states for whatever they are promising?
Yeah, two things there. One is the project design there. A few weeks ago, actually, DEC offered a course in social accountability, and they were discussing how can we use social accountability tools to improve the effectiveness of the projects that we have at the World Bank. And it seems to me that not only in the World Bank projects, but in health policy all across the board, social accountability is a very powerful tool. Of course, it has to be context-specific, very carefully designed, planned, and implemented and monitored. But it can really increase the outreach of many of the programs we have, of the projects, but also health policies. It can actually help us identify gaps in implementation that we would otherwise have to wait several years till we gather data. So it's a very, very powerful tool, yet it has to be very carefully utilized. When it comes to outcome variation and the kind of social contract around information, I cannot but think of human rights in that context. Human rights is also something that is still evolving. Yet human rights ask us to think, in particular right to health and rights-based approaches, asks us to think on outcomes. So let us improve the health outcomes of population progressively over time. So we cannot do anything else but to measure outcomes, right? We cannot, in order to work using a rights-based approach, we cannot only measure inputs. But measuring outcomes is quite tricky because A, we are learning. B, one thing that we've realized is that there is not a social contract around the right to information. So who has the right to use or to provide or to collect data around outcomes, and how do we use it, and who sits in the table? So when it comes to talking about outcomes, you get into the political economy of a very knowledge and information heavy industry as health, and it's a very political economy tricky question. And I think there is a multi-stakeholder work to do there, beginning with a social contract around right to information, where transparency of who collects data, how data is utilized, who gets to access that data, and how often do we publish it. It's cornerstone towards this process. It's somehow mimicking to some extent the shared decision-making process that hospitals are doing.
Could I turn to you on that precisely, because you were mentioning outcome variation and process variation as such an important cornerstone piece of the learning and adjusting the interventions that need to be done to do the right thing right. So that means for me that there was some kind of agreement to be perfectly transparent with the information somehow, somewhere, at some point, so for everybody to be able to obtain the results of what is happening and be able to do outcomes research. So how did that happen, that people agreed to put their information out?
Well, at one level, let me just describe how important it is that collaboratives be formed that are willing, communities of practice, that are willing to be transparent about their processes and their outcomes so that they can learn from one another. Dartmouth founded something called the High Value Collaborative here in the United States that now includes 18 healthcare systems that have agreed to be transparent with one another and to publish their results. And as a result, they are improving processes and lowering costs. They have to build models, methods, metrics to bring discipline to that process. And our observation is that we could learn a lot more if, in addition to in the United States, we had the same models, methods, metrics pursuing the same hypotheses in the largest planned healthcare economy in the world that put a stake in the ground for equity in 1948, and that's the NHS. We could also learn a lot if the same models, methods, and metrics were applied in collaboratives in China, the largest emerging economy. We spend 18%, the UK spends 9%, China spends about 5% of their GDP. There's a lot more room for innovation and transformative innovation with less disruption in China as they build the infrastructure. So I think transparency about process and outcomes is critically important. The piece that I think is more related to the rights-based approach is not just transparency about outcomes, but transparency about patients' preferences for the outcomes that are achieved or not. You know, what the economists would call the patient's utility for the state that is produced by the service that's delivered. And that's where this whole notion of warranted variation as opposed to unwarranted variation comes from. You can deliver a process absolutely perfectly and achieve the very best outcome with that process. But different people are going to feel differently about exactly that same outcome. And you can measure patient preferences. You can measure utilities. You know, economists use one set of scaling tasks that force choices. Psychometricians turn more to scaling tasks. But if you measure patients' preferences, you are getting much closer to a science of delivery that includes metrics that get you to value and its production for individuals who live with the consequences of the service. And so much of what we do in what we think about in healthcare delivery science is finding ways to engage. And I like to go back to the Declaration of Alma-Ata. What Alma-Ata said was that healthcare is a basic human right, but with that right comes a duty and a responsibility for the people individually and collectively to be engaged in the design and implementation of their health system. That's where this bottom-up notion that's where the value comes from. Right? So, and we've developed what we call decision quality measures, where we measure how informed a patient is. And once they're informed, we then ask them, what outcomes would you prefer? And now that you know the relationship between the different treatments and the outcomes, what treatment do you prefer? If we had transparency of that kind, it would be transformational in a science of service delivery. And again, it applies well beyond healthcare. Let me give you an example. This is so abstract. We've been working closely, in addition to the UK and China and the US, we've identified some developing countries that are low and middle income countries that are very interested in this approach, and among them are Rwanda and Peru. And Agnes Beniguajo has spent a good bit of time at Dartmouth, and she's coming back this month. And in a conversation with her about understanding what people's values are as you're trying to provide service delivery and how that influences investment, we settled on this notion of her need to build facilities that will provide curative cancer care in order for her people to understand that Rwanda is moving in that direction, and they're moving forcefully in that direction. At the same time, she understands how important engagement is and how important it is for people to understand that the hospital is not a dignified place to die, particularly a hospital in a developing country. A really dignified place to die is with really superb care, with family at home, when that care comes from the community and is provided by well-equipped accompagnators or promotores. That is a question, and you know, in the United States, we've invested so much in building hospitals and training hospitalists and intensive care units and training intensivists, and so little in that kind of community-based care. Is it any wonder that 55% of Americans who say clearly that they want to die at home die in the hospital? So this is a very so Agnes understands that she has to balance the investments. She has to be investing over in the community-based, and that's all about educating people enough and giving them a sense so they don't develop these inappropriate expectations of where they should want to die. Is that?
Yes, so it seems to me that you're talking about human dignity as well.
Yes, and I hope that resonates with a rights-based approach. I mean, if the right should be the right to know, the right should be the right to have realistic expectations about what technology and science can and cannot do in a certain health predicament.
No, absolutely. Can I make a comment
Sure.
there? It totally resonates. Before we mentioned that rights-based approach in human rights about achieving outcomes. But the second part of that is about making sure that you implement a fair process by which you reach and you revise a decision. And what I hear Al saying is that in as much as social accountability can improve the effectiveness and efficiency of health spending, there will be a point at which we cannot afford as a society to invest dramatically more in health. So we will have to make tough decisions. Do we pay for oncology treatment or do we pay for rheumatology? And that is not an easy decision. It is definitely not a technical decision, definitely not a technocratic decision. It is a social decision. And in this decision-making process, what I hear you saying is that you incorporate individuals' preferences. You incorporate human dignity. And at the medical facility and at the human rights, from a human rights point of view, at the population-based approach, we are expected to incorporate population's preferences and bring them to the table and reach a fair decision that is, at least in principle, uncontestable, given that the processes by which we reach that decision were fair. So it is, it totally resonates. And it's dignified for individuals and population as well.
Thanks. I have a lot of questions I want to ask both and then to get a little bit into the politics, but maybe I will just do two. And you make me think of the following. I mean, and probably you all hear the same thing every day when I drive to the office. I listen to NPR, National Public Radio, and they have this ad about the Gates Foundation that says that, they are doing what they are doing because they believe that every person should have the chance to live a healthy and productive life. So when I think of that, it's like, okay, if everybody needs to have the chance to be healthy, it seems to me that then health is a right. But then if we're trying to also support countries on moving towards universal health coverage and trying to give everybody the chance, we are having a dilemma here. And I have heard a lot about that the right to health is not an absolute right. What does that exactly mean?
The absoluteness of a right exemplifies something that is very funny. I'm a physician by training, and when I started working in human rights some 6-7 years ago, I didn't understand the concepts. And then when I understood them or began to understand them, I realized that those concepts we also applied in health policy and in development. It's just that we were using different terms for them. An absolute, a non-absolute right means that it's subject to budgetary restriction. Okay. So human rights understands the fact that we cannot provide everything to everyone all at once. It understands that we have to set limits, therefore we have to set priorities, therefore we have to achieve or walk a path towards universal health coverage. Yet it asks us two things: to be as efficient as possible and to be as fair as possible given our budgetary restrictions. And of course, again, fairness means participation, all the things we've discussed. But it from the onset, even from 1966, when the International Covenant was signed, then in the Alma Ata, and then in 2000 when the General Comment 14 that develops the concept of right to health, outlays it, it has been very clear that it is not an absolute right. It is subject to budgetary restrictions.
That solves my problem, because then this progressivity actually makes a lot of sense, but then it makes a lot of sense on what Al was talking about, measuring the results and measuring the results of this progressivity to see if we're really getting towards there. So I wanted to let people to get into their questions. What I have been listening from both of you seems to me that there is a lot about participation, shared decision-making, transparency on the information, empowerment of patients, and that it seems to me that, and human dignity, that these are all principles of rights-based approach to development. And then if I look at the two things that you are working with, I ask myself, is it the way to implement and for the audience as well, and the two of you, is it a way to implement or operationalize a rights-based approach using delivery science?
You want me to start?
Sure.
I think a lot of this is about knowledge power hierarchies and flattening them. As I said before, the core resistance, I think, comes from this wanting to believe that the trustworthy people who got through organic chemistry are the equivalent and can execute and deliver the right service is profound. Finding ways to move people and populations away from that thinking towards more engagement, towards where the declaration was pointing us. And I think there are lots of ways to do that. Part of it is just bringing different disciplines together. One of our we've drawn heavily upon the management sciences at Dartmouth, including marketing. And in many medical schools, that's a dirty word, right? But if marketing is understanding, the marketing framework is all about what's called intelligent enterprise. There's an iconic professor there. We said in service world, the smallest replicable unit that you want to focus on really executing well with is the producer of the service at the front end interfacing with the patient or the receiver of the service, the consumer of the service, and the critical exchange of information about what's possible to produce and what's valued. You go through this last night at a restaurant. Right? What's possible and what's valued. That's the critical element in a service industry. So it's all about engagement. Some of you may know about motivational interviewing. We change patients' behaviors in healthcare most effectively, not by telling them what to do, but by engaging in a conversation where the goal is to get them to talk as long as possible about the discrepancy between their goals and their behavior. The longer they talk about the discrepancy, the more likely they are to change their behavior. Now, if the goal is to get them to talk not 10 minutes, but 20, 30, 40, 50, is any doctor ever going to think that's a good use of their time in any country? So you need to radically redesign the team. Over in population health and primary care, where Alma Ata was trying to send us, it's not about highly trained people doing things to others who are anesthetized or otherwise incapacitated. It's this knowledge-intensive service industry model. And we need to radically redesign it and get the people in the population to accept it. Some of the things we've done to do this, and believe it or not, so Mary Flanagan is one of our favorite colleagues at Dartmouth, and she's a professor of the digital humanities, and she's one of the most creative game designers in the world. I built a strong relationship with Mary when I said, I think that the humanities are really important because agency questions are rife in the dysfunction of healthcare. And she said, I couldn't agree with you more, and she took a card game out of her pocket that she had designed with Dartmouth students, and the card game is called In the Village, and it is played by people in sub-Saharan Africa, and it's meant to teach them how to work together to prevent morbidity and mortality from malaria, and it teaches them a lot. There are cards that represent adults, pregnant women, children, so they very quickly learn that the children are the ones who are most susceptible. Right? There are cards that represent the medicines, but also cards that represent insecticide and bed netting. So the rules of the game get them to learn the importance of the upstream rather than the downstream interventions. And then there are obviously cards that represent mosquitoes. So so we see that as delivery science. We see that as a means to engage people in creating collective and individual agency so they can care for themselves better in these low resource settings. The interesting additional piece in this agency evidence is, as I think we would all agree, the UK did put the stake in the ground for equity in 1948. Free at the point of service. Virtually everything. Now, not everything is free, but almost everything is. They have the same level of variation that we do in the United States. They spend they have 152 PCTs. They spend 3 times as much on cancer care and heart care in one PCT as in another. They invested dramatically in capacity to do coronary artery stenting for stable angina, and the rate varies tenfold among 152 PCTs after they built the capacity. What's going on there? How did they know that that was the capacity that they should have built? Right? And interestingly, NICE International is trying to disseminate their guidelines in developing countries. Well, guidelines represent top-down judgments, right? There isn't anything about the utilities, and how do you feel about this medication as opposed to this medication? So I can't emphasize enough how important I think engagement is. And just coming back, if there were, I won't take the time for one slide, but if you work with me, if you imagine this being level of training for a health professional, this being level of training for a health professional. Just don't want to see how sophisticated my notes are here. This being level of training, and this being difficulty of the task. And think about any country in the world, the U.S., Eritrea, Rwanda. And this, it's number 11. Thank you, Dan. There. Okay, go back one, Dan. Yeah. So level of training, difficulty of the task. And at the high end there, you've got the fully trained professional, dual boarded in psychiatry and internal medicine, can take care of any complex patient, or you've got the surgeon. And obviously at the high end on the vertical axis, you've got that complex patient's planning process, care plan process, or you've got the surgery to do. The horizontal line is incredibly interesting if you think about not the horizontal line, the diagonal, because everything below that is potentially inefficient. And everything above it is potentially unsafe. You don't want the promotori doing the surgery, right? And you certainly don't want the surgeon doing the motivational interviewing or the shared decision making, because the resources are constrained, and there's no way that's a good use of their time. You would like them to work at the margin after the basic information is obtained, or after the 2 hours of discrepancy is described. But everybody gets anxious about that because it looks like Taylorism or Fordism, because there's only one sweet spot for any level of training. So the next slide says, how do we create shared goals, shared knowledge, mutual respect among teams so everybody has each other's back in delivery? So this whole notion of teamwork, and can you measure teamwork? And this measure called relational coordination actually comes from the airline industry. Southwest Airlines got their planes off the ground on time more often than United and American because their teams had relational coordination. They had shared goals, they had shared knowledge about interdependencies, and they had mutual respect that was measurable. So these are the kinds of measures that I think will become an increasing part, and so many of them are about engagement. How do you engage individuals and patients?
Seems to me that both of you are talking about change of behavior and understanding of many stakeholders. So the political economy of this is really difficult. I mean, to try to convince governments that they need to think of having a rights-based approach for their development of their decisions and policies. As you were saying, guidelines are top-down. So we need to have people participate and empower them to say what they need and so on. But how to handle all
data, and data about what people value. So one thing that I didn't mention is here in the United States and in other countries in the UK, if you look at the distribution of bypass operations or prostate operations or the rates at which various cancers are treated aggressively in the United States, and you give people information and you check, you be sure that this is an informed decision on their part, and this is what shared decision making is all about. And you also let them hear from people who've experienced the outcomes so they can more accurately imagine the alternative futures. They make dramatically different decisions. So in the United States, I mentioned that the bypass surgery rate ranged from 12 per thousand to 3 per thousand in the Medicare population. When people were engaged, and it doesn't have to be an individual. You can build tools to do this. You can imagine people doing this with iPad interventions, engagement interventions, as well as decision support. When people were engaged, the rate fell to a rate lower than all of the 306 hospital referral regions in the United States. You know, when you look at that kind of distribution, your eye is drawn to the mode, and you say there must be overutilization here, underutilization here. There's a slide of that too, Dan. I'm not sure what number it is. It's actually worth putting up. Go back, Dan. Keep going. So right there, this next one. So if you engage people in shared decision, those are 306 dots representing the 306 hospital referral regions in the United States. And as I said, your eye is drawn to the mode, and you think that those high rates are overuse and the low rates are underuse. But when you get people to engage and they understand the relationship between treatment and outcomes, and they're given the opportunity to anticipate how they're going to feel about the outcomes, look what happens. It's hard for a policymaker to say, let's keep investing in capacity to do bypass surgery, right? If you have it, particularly in a place with low resources. And these are exactly the kind of interventions that people sue for on the basis of a right to health.
2 or 3 very quick comments. Just to respond to your question on the value that I perceive on delivery science to human rights and rights-based approaches. Right now, we have 2 billion people without access to medicines, right? 2 billion people. The interesting figure there, the sad figure is 2 billion people. The very interesting figure is that nearly 1.3 billion people, of those 2 billion, have de jure access. They have been promised that they were going to give access to medicines. So it seems to me that this closing this gap between what is promised and what is actually delivered, it is something that probably participative uses that you guys are implementing could be useful. One of the most underdeveloped or underused resources that we have in healthcare is our communities and our patients. So I think that is dramatically something that we have to. And you've said it before, Maria Luisa, it's a shift in paradigm. How can we use ICTs to broaden the spectrum of decision-making and broaden the spectrum of monitoring of the implementation? That is something that comes striking to me. The second comment I want to make is that as of now, right to health and human rights is deontologically right. It is good because it is right to do. Yet we have to analyze the consequentialist point of view. Is it adding value? Is it adding efficiency? Is it adding effectiveness? And it really depends on the context. But it seems to me that delivery sciences can provide a framework by which we can measure that. Context specific. Again, it is right to do human rights approaches, yet we don't have enough evidence that provides additional evidence, effectiveness and efficiency. And last point is a little bit of disagreement with you all regarding clinical guidelines. I agree with you that clinical guidelines can have a more bottom-up approach, yet in developing countries, the absence of clinical guidelines, or let me put it the other way, if we were to have clinical guidelines in developing countries, we could increase the sensitivity and the specificity of the social contract for a subset of clinical conditions, and by doing that, we could increase both the transparency, but also the empowerment of citizens and patients. So we can even do it better, but as an instrument, it could be a good starting point.
I agree with you entirely, and I think essential medicines lists sort of fall into that zone of effective care. Here's my slide again. If you think about level of uncertainty about the impact of an intervention, I don't have this one. If you think about level of uncertainty along this axis about the effect of an intervention, and disagreement about the value of the intervention, where this is low, this is low. This is called a Stacy diagram. It's used for down here, where there's very little uncertainty about whether you get a good outcome if you do something, and there's very little disagreement about how that good outcome is, how good that outcome is. Then for sure, it's all about process execution. It's all about getting it done. It's all about delivery. But if there's uncertainty, and if there's disagreement about how good or bad an outcome is among individuals who receive the service, you've got to pay attention. You've got to pay attention, or you're producing harm. An example related to drugs of how important engagement is Simone Schonett at Dartmouth, who's an economist who came from MIT and was supported by the center early on. just published a paper looking at use of antimalarials with very, very strong subsidies, reducing the costs dramatically. And they did community randomized trials, and what they found was that the subsidies dramatically increased access to the drugs and utilization of the drugs, but only 56% of the people taking it should have been taking it. There was this remarkable false positive rate, if you will, 44% of the people taking these drugs, and that has profound implications for resistance to those drugs in the future. So, when Simone told me about that, I was thinking about, wouldn't it be wonderful to do, and this is in Kenya, wouldn't it be wonderful to do a trial that somehow included Mary's card game? I would bet on Mary's card game having more of an effect on malaria morbidity and mortality than on subsidizing drugs and creating better access, particularly if you had a long enough time frame.
So it seems to me that both of you are talking about something quite similar. It's also about the process on how to get into those clinical guidelines and how to implement them and so on, and how to empower people to be able to really understand what is what they would like and they can say what they like. I don't want to go more into other questions that I will have and love to hear about, because I would like to see people would like to probably hear something from both of you. So I will open it to questions from the audience. So there's one here, Nin, and then Joy.
I have several questions.
Sorry? Yes, no. You have to use the microphone, otherwise people on the web stream cannot hear.
Thank you. I have several questions. This is fascinating, first of all. I felt my first comment has to do with sort of the focus of the discussion today, this morning, on the signs has been very much individual level care and treatment. As a public health, I'm also obviously see a lot of tremendous relevance for how we think about prevention services. And it'll be good to get some sense from you how, because even, when we talk about patient, we're hoping that we get to people also before they become patients, right? So I'd like you to discuss that. The second part is also social values. I completely agree with you that we have to understand the preferences of patients, consumers, but we also have to realize that social values change. In fact, when you work in an area like HIV/AIDS for the last decade, we actually are actively involved in changing norms and values about how communities approach certain conditions. And I want to. My third question is how do we sort of complicate this notion of social values? And the third point is I really like, Dr. Mulley, what you talk about multidisciplinary involvement, and that the importance here is on the how and not just on the what, and the how of getting it and the processes that are very important to getting the outcomes. And the way I understood that was that we need to do a better job of measuring the process. For example, whether it's when you talk about in your table here with mutual respect, but I also think it's about process of how do you get to shared decisions? How does social accountability and engagement of citizens, whether at the clinical level or whether at a more institutional societal level, I think we do need to learn how these processes do improve and get to the outcomes that we want, and we need to continue learning because I'm sure it's very. So I just wanted to make those comments and really hear your responses.
Should we collect the next question
Sure.
also, and then we go? Joy?
I'm going to restrain myself to only one of the 53 questions I'd really like to ask. So if I were a health minister sitting here today, I think my strongest reaction might be 20 to 40% waste. You mean I could, so where do I, provided I can get over the resistance to accepting that might be the case, my burning question would be, so how do I even start to find some of the biggest sources of that waste and put them right? How would I begin?
Well, one of the things that we've been trying with great humility, trying to put on offer from Dartmouth are tools derived from the 30 years of experience that I described, studying healthcare largely in two developed countries, the U.S. and in the U.K. So there is something called the Dartmouth Atlas of Healthcare, and that Dartmouth Atlas has 306 regions, and it's all about inputs and outputs. A very basic way to begin to think about waste is looking at inputs and outputs and geographic variation in those inputs and outputs. And so we are working with colleagues in Peru. We're working with colleagues in Rwanda. We're working with colleagues in China to think about how countries at various stages of health system development could build atlases of healthcare that demonstrate the relationship between inputs and outputs, so you can identify where the waste. We know in America that there's a lot of waste in Miami. We know that there's a lot of waste in McAllen. We know that there are communities that are positive deviants. And what we're trying to do at Dartmouth, for instance, is really engage the community and say, we're sort of in the middle of the pack. Can we intentionally become a positive deviant? We've also created a radically redesigned primary care system with that kind of model in mind to try and help us get there. So inputs and outputs is a critical piece of it. Other tools that we've developed something called this high-value collaborative, where we have to have models, methods, metrics for use in the U.S. They don't have to be terribly different in the U.K., and they don't even have to be terribly different in China. So we're trying to build this trilateral coalition of collaboratives with the largest market-driven healthcare economy, largest planned economy, and an economy that's trying to figure out what worked in the market-driven and what worked, and take the strengths from both. We've also created this curriculum, and it's a starting point. We've pieced it together. A lot of management sciences, a lot of operations management, management budgeting, management accounting, strategy, marketing. A lot of population health and primary care. I'll come back to your question, I'm sorry. A lot of population health and primary care, integration issues. We've been using that setting, bringing best thinkers from across disciplines. We have visiting professors as well, where we don't know all the answers at Dartmouth. But again, as I mentioned, we've been trying to intentionally and iteratively connect the best thinkers with the best doers. So a member of this year's class is essentially the Chief Implementation Officer for the Ministry of Health in Rwanda. So one response to the minister would be, here are a bunch of tools. We're trying to build capacity across contexts. We want to learn from what you can do that we can't, and we have a lot to learn from what Rwanda can do in the U.S. And we also want that to be shared so we can discover what next steps are together for you and for us. And coming back to your question, I meant to include, when I talked about, I know a lot about primary care. I added a textbook on primary care, a big one. And I think that 80% of what happens in primary care is this knowledge-intensive service industry. Very little of it is doctors doing things to people, or most of what we do is ritual. Much of it is the exchange of information necessary to know when to standardize care and when to customize care. I think public health is a different kind of knowledge-intensive service industry, but it clearly sits over there. It's not highly trained people doing things to other people. It's about engagement. And that's where I think the efficiency gains in a place like China or in most developing countries are extraordinary. China's currently investing in training 450,000 family medicine doctors with the same curriculum that we've trained family medicine doctors. They're going to end up at the same place on the hierarchy where our family medicine doctors sit. So they're not going to be real change agents. I think they could train 20% of that number, and instead train millions of promotories, accompagnateurs armed with, it was the first rural cooperative medical system that inspired the Declaration of Almada. that was all about integration of public health and primary care. And I think if they went back there and replaced the barefoot doctors with iPad doctors, and the iPads were loaded with engagement tools rather than just the decision support and the essential medicine lists, it could be transformative. And then the other two, social values, you know, at some level, to say you want to change social values, you know, that's what Wall Street does. I'm not Wall Street. I'm sorry. That's what Madison Avenue does, right? We're persuaded by marketers who are inducing demand for services to misimagine the future if we do something. A lot of that has crept into healthcare around the world, all these expectations about what science and technology will do. That's something that I would like to change. I would like to see people feel more of a sense of individual and collective agency in determining their health futures. That's something I'm pretty comfortable with. But other social, you know, trying to intentionally change other social norms in different cultures is too big a question for me to answer now, I think. And then the third one was the importance of how. I couldn't agree more, but I would just add the importance of context. You know, whether it's organizational culture, whether it's a national culture, whether it's low resource, high resource, whether you're in the middle of a difficult political struggle because there's an effective change agent or an ineffective change agent. The hows vary a lot.
Just to make it, leaning into your point on measuring the process, I believe there is much room to do there in measuring what works context specific, what lessons can we derive, and what can be amplified and what cannot be. And yeah, there's much to do there.
Jerry?
Thanks so much, Maria Luisa and WBI and the Health Network for organizing this. I found this discussion very abstract and kind of Anglo-American. In my, I wouldn't call it vast experience, but experience now on 3 continents, there's a huge educational, caste, cultural, social class divide between white-clad urban doctors and many people who go to different clinics. As an American, and most Americans, there's been research on this, we challenge doctors. I don't, and not because I'm a public health specialist. My brothers have nothing to do with health. They never take a doctor's word. We never have for many years, and we always always challenge doctors. That's very difficult in other settings in which people are cowed by doctors. There's a huge agency issue here. So I'm just wondering. I'm not saying it's a bad idea. I'm just wondering that there's a lot of things that have to be changed in broader society before some of the things that were talked about will be said. Social accountability. There are many cadavers of failed programs of social accountability dotting the third world landscape. I know of cases that are very short-term, that have been very successful. India, Africa, a couple in Latin America. Long-term, not a very good record. Not a very good participation record, for many reasons to do with the political institutional context of those countries, that in which we have patrimonial bureaucracies, okay, and not necessarily bureaucracies who inform want to do the good thing, but in function really don't. I mean, this was kind of brought up before about the gap. So I think that there is a lot to do in higher level institutional arrangements to get downstream doing the right thing, because the systems don't necessarily respond to the objectives and the policies. Policies are great. In some countries you think you're in policy heaven, but they don't actually work out that way. Okay, and I think that a lot has to be done to understand that. Those are just comments. I'm not expecting a response to that, just Jerry venting. However, I do have a question. This is going to follow up on Joy's question a little bit. Okay, so I'm across the table from the health secretary in Kerala, or I'm across the table from the health secretary in Henan province in China, or a health secretary in Vietnam. And I'm just trying to get my head around, because I see some really, I saw some really good things. I saw something in the slides there, and I heard some great things. If I say, and they say to me, okay, my service delivery system, there's no trust. I have problems with my service delivery system. We're not converting resources into effective service delivery. Okay, they won't actually say that way, but let's just say it's something like that. And if I come back and I say, Dr. Mulley, how about an atlas? How about a curriculum? They're not going to really be that interested in dealing with me. So what exactly, and I liked your comment about this combining research agenda with the operation agenda. I didn't hear that much about the operation agenda, but what would we say in terms of what Dartmouth has been doing that I would be able to engage with that secretary about improving his service delivery system, and he has a window of maybe 1 or 2 years.
Let me first respond a little bit to the venting, which I appreciated. There is an Anglo-American cast to what I was describing, largely because that's where Dartmouth's historical work has been. But what's interesting about it is that Dartmouth's work has been a very contrarian view, and has presented a very contrarian view of healthcare and the way the system's designed and the top-down nature of it. And that's a contrarian view whose time has come in the United States and in the UK and in China. Shared decision-making is peppered throughout the Affordable Care Act. It's the number one policy issue in the coalition governments, and it's very high on the policy agenda in China. So this notion of engaging in order to know where to invest to create value is beginning to take on some international legs. And if China could embrace this and really show what's possible by shifting that investment in family medicine doctors to the knowledge-intensive service industry, my guess is a lot of other countries would follow. So what we're trying to do is don't make our mistakes. And we've got British colleagues saying, don't make our mistakes. Don't think that you need to build all these hospital beds and not invest in the community-based care. So that's my response on the Anglo-American. We're very well aware of it. Jaime has real practical experience with delivery science in Peru, but I don't. My experience in Uganda, Honduras, and other countries in Africa and Latin America is limited. With regard to the response to that minister, I think I would have to say 1.5 years. It's a very short time frame. We've been dealing with problems that have existed how long, right? And we've got some hypotheses that we are testing with your peers, and we've got some hypotheses that we are testing in the United States and in the UK and in China, and they're all the same hypotheses. And we're trying to create this knowledge resource that is based on a sense of mutual learning and understanding, and a core element of humility. We would like you to be part of that. We don't have the answer for you, but boy, we do have some mechanisms for you to learn how to ask the right questions about what's wrong with your delivery system, and we would like you to come in. I think that's the best I could do, and then try and give them the opportunity. We're working really hard. I mean, one of the things that we've had preliminary conversations about is how might Dartmouth expand its reach into developing countries by identifying people like Jean-Pierre from Rwanda, who is as likely as anybody to be a minister in the future, and who is in this master's class, and is actually in an action learning program with students from China, Kosovo, and the U.S. doing a study on cross-cultural resistance to shared decision-making in their countries. So we don't have the answers, but we've got a lot of hypotheses that we would like to build partnerships to test across contexts.
I may say one thing, thinking on what Jerry was saying, and remembering what I saw during HD Week and what I saw much before when we went to the Middle East with Mary Lou Bradley, who's here, and they have this idea of making a video of from general people on the streets asking them about the healthcare and what they thought. And just makes me think that these things didn't happen 10, 15 years ago. So there's a lot of things that are changing very rapidly that makes us also think, maybe on your second point, Jerry, on the institutional arrangement, that maybe how do we design systems that will allow just by itself, I mean as a normal thing, to put the information out, to do research on outcomes, to learn from those and introduce specific policies. So how do we go to a point to get systems that are transparent, that their processes allow people to participate? Because what we have today in systems and the way they are organized and the way they work, they don't allow for any of those. So there is nothing of that as a normal thing to happen. So of course it's a shock. It's like how to introduce participation. Oh, this is not going to work. How to make it transparent? It's always a friction because none of the structure is made for that to happen. So it makes me really think like, oh gee, maybe there is something completely different that we have to be thinking about that I don't know exactly what it is or how it is. The other thing, the last one is, because we lived through the ministers having 9 months in the job and then going, or 2 years. I think that's the value then to think about engaging with other key stakeholders that are there. So we know that people in developing countries rotate a lot. So today they are in the think tank, and tomorrow they are in the government, and the day after they are in the university, and then a month later they have their own industry. So, but they are all the same people. So I wonder if strategically have to think, okay, we have to look for which are the stakeholders that really can influence decisions and try to put them at the table. Those are my reflections. You were going to say something, sorry. And we are taking also the time for the coffee, so maybe that will be the last thing, if people want to have coffee and then come back to listen to the Peruvian experience. Go ahead.
Yeah, I was a decision maker for 7 years, and I understand both Joey and Joyce and Jerry questions from the political angle of a decision maker who has 12 months to move forward his career, right? So you have to present him or her a long-term policy perspective, as also a short-term quick win that he can put in his resume. To Kerala or to these guys, I think there is a terrific tool that contributes to all these discussion is registry of patients for NCD conditions. I think it's very underutilized, and it brings much value to healthcare and also to right to health. But the other comment on cadavers, I love that. I think we have to learn from cadavers. I like to think of that back in the Middle Ages. A Spanish monk, actually did dissect a cadaver of a woman. And that was not allowed. You could not dissect a cadaver. That was prohibited by Catholic Church. And he found that that woman had only one uterus. And he had read Galenus, the famous Roman physician. And Galenus had said women have two uterus. So that monk that dissected that cadaver said, well, she has one uterus, she's anti-natural. Because theory says that women have to have two uterus. So I think learning from cadavers is great, and I presume that much of the implementation of the UHC movement could have been could actually learn from the cadaver, if we want to call it, of Alma-Ata. And I think learning from cadavers is great. My point to the cadavers of social accountability, there are a gazillion of them. And I was a victim of social accountability back in the days in the Colombian government. But one of the things that we have to learn of social accountability is that we do not have the measurement techniques to properly assess whether social accountability is good or bad. And I go back to your question. We don't have the ability to measure whether processes are of social accountability are well implemented or not.
All right. So unless anybody has a burning question that I will suggest that they can ask it outside. There is some coffee outside, and I want to thank very much Al and Leonardo for being here and all of you. Thank you. And we'll have to use like 15 minutes for the coffee, and then we'll come back to listen to the Peruvian experience and the implementation of science of delivery in the case of Peru.
In terms of, what is the thing when you get there? Yeah, no, exactly. I mean, this is, of course, there's work on the way, there's also work on the WTO. Right? And then you need negotiations, and then you need and then it's like about no, it's not, it's all
That was for making everything happen. It's really like these lights are like so warm and so bright that you can't see the people. Oh, it's really like a little funny. Yeah, so I felt like it was those military investigations. They took the light and they say it now. But from here, from our perspective. Oh, I didn't realize. How did she know that? No, I didn't.
I might have heard of it. So I recruited. She works a lot with Toby.
Oh, really? Oh, okay. I know. I don't know if you know anyone in oncology. Health insurance fund for the poor. Okay, I was going to say a couple of board members are on that, and a lot of people are kind of familiar with what we're doing, but.
Video conference, they say, oh, we have Mexico invited, so connected. It's a little bit different the way I know it. But you may want to give them a call. That's fine. That's when you can take that.
I don't know, but if you call that number and you take the registration number, maybe they can tell you. I'll do it later. Take notes. ¿Estás listo?
Thank you.
Yeah, I am actually really late. Can you start? Hey, Lisa, just tell me when we kick off. Are there more people outside? We told them to bring their coffee. Yeah.
So good morning, everybody, and welcome to the continuation of a morning session where we actually had a fantastic presentation by Al, and then a nice dialogue between Al, Maria Luisa, and Leo, which I think teased out very nicely the understanding of the science of delivery, but also how do we apply it and how is it sort of integrated into other aspects. And now we go into real practice, and we have Dr. Jaime Bayona, who's the Director for Global Health Programs and Practice at the Dartmouth Center for Health Science Delivery. And before joining the Dartmouth Center, Jaime was in Peru, and he was leading the Peruvian branch of Partners in Health, which is called SES. I'm not going to pretend and pronounce it in Spanish. I tried in my mind, but I couldn't, so I'll leave it at SES. And I think what's important here is really sort of bringing in or weaving together the actual practice of this science. And when Jaime was in Peru, he had a very, very successful experience of actually addressing MDR-TB, which is multiple drug resistance TB, and that's why we call this session almost the art of the possible, because it was something which was felt was impossible to do, but then taking a very holistic, integrated, transdisciplinary approach to it, where you were not working in silos of medicine, but looking at a whole aspect of TB patients. Jaime was able to address that problem with his team. So. And today our discussant is Nicole Klingen, and as a lot of you know her as the acting director in HDN. And what I'd really love for Nicole to do is then take the lens of the experience of Peru and really see how we can apply it to our problems in the health sector that you come across every day in multiple developing countries. And then hopefully we also want to see how do we then integrate that into other sectors and other practices, such as infrastructure and cities, urbanization, climate change, education, and so on. So really, while we are coming at it from a lens of health, we are really looking at how do we take this and apply this iterative, evidence-based approach. So without further ado, Jaime, the floor is yours.
Thank you very much. Good morning, and thank you for the opportunity to share this story that started back in '94 when Dr. Jim King and Paul Farmer decided with other members of Partners in Health that it was a time for starting the Peruvian branch of Partners in Health there, and the name was Socios en Salud. And what you are looking at right now is the staff that was part of the first team, and they were just graduated from high school, so none of them have a professional training, and we invest about a year training them, learning more about the Peruvian culture, but more importantly, learn how to do research, doing the qualitative and quantitative research. And that was with the support of colleagues from Harvard, but also from Peru, who were very interested to see, how this experience will end up. And when we started, I was told that I have to work in a very limited budget, that it will be no more than $45,000 in a year, and I shouldn't be working beyond the district of Caraballo, a poor district of 120,000 inhabitants. So as much as possible, low key, not big noise in terms of what was going there. But one of the problems that we realized very soon in that area was cases of multi-drug resistant tuberculosis. And you are looking at now Paulina and Percy, and I will describe a little bit this story. And the picture was taken because Paulina was 1 hour before that picture at the emergency room in one of the hospitals in the northern cone in Lima, and I was with her, and the doctor was really upset at the emergency room. He was telling her, I told you, we already tried what we have. We treat you for about 3 years, and there is nothing that we can do for you now. So I'm sorry, what they are telling you, and they, meaning Socios and Salud team, is not true. There is no treatment for you. I mean, you can check all the literature, and it's impossible that you can be cured. So she was really sad leaving that emergency room, and I was really upset about it. But when we got home, she was really trying to figure out, this is going to be probably the end. So I want to have a picture so my son Percy could have, some memories of these moments later. And at that point I can probably, try to understand why the doctor was behaving that way, and why that kind of messages Paulina was getting. And one of the reasons was that was because the international community was saying everywhere that treating multi-drug resistant tuberculosis in resource-poor setting was not really possible. And the fact that treating an MDR-TB patient in a hospital in New York cost $250,000 per treatment, was really a huge amount of money that a government like the Peruvian one could really afford for treating a large number of cases. And and we were told that the number of cases like Paulina in that area was not big. Why are you making so much trouble with 10 cases? We have to take care of the large number of tuberculosis patients that we have in the country. We have 30,000 cases of TB every year. Why you bother by 10? We have to focus our budget in a place where we can have a more meaningful outcomes. So knowing that what we have actually in the country, so I have to acknowledge that the tuberculosis program in my country was a good one, and and 1 year before that picture, the national TB program in Peru get an award as one of the best TB programs in the world. So what we were doing is actually challenging a very successful program to do a work that will require an extra effort. But again, the international community was saying, please don't even try. Get focused on what is your largest problem, and not even pretend to treat multi-drug resistant tuberculosis. So the first group of health promoters were really in a position to know very well the community, who were the actors, who can really learn how to start solving each of the problems. And I learned from my colleagues in the country that the team that was really successful in implementing the DOTS strategy in the country were the groups coming from the nurse team. And I tried to follow the same, the same example. Not really paying attention to the doctors, not really paying so much attention on the specialists, but trying to work something that could be really easy to implement, training a group of young nurses or even a nurse student there. And certainly we have to train a large team, but I just want to highlight which was the core team in that process. And as you can imagine, they were a small team. They didn't have any experience working on health, and we have to implement right away a formal training and an informal training. We were told that there was not really an epidemic, only few cases, but we thought that the data may not be showing the reality, and we have to start training more and more members of the community, just in case the number was not quite right. So at the end of this first phase, where we invest a lot of in terms of training the staff, we have a very, very good, small, reliable team who can actually take, biggest responsibilities. And I just want to make a comment here that when we were in the process of training community health workers, the best way to assess that they were actually capturing the essence of treating MDR-TB on ambulatory basis sometimes was using games. And in this way, in this picture, they are playing domino in a way to learn how to deal with side effects, but not that we were trying to teach them, what kind of medicine do you use when somebody had a side effect. It was trying to give them the concept that side effects is part of a treatment, and you have to talk with your doctor and decide what will be the best option at that moment. Maybe your doctor wants to stop the treatment, but when the patient knows, that stopping the treatment could create more risk. So it was a very interesting dialogue between the patient, the health promoter, and the doctor in the same room discussing about what will be the next step for the treatment. So we were trying from the beginning to build a team when the members of the Ministry of Health, the NGO, the patient, the family, all working together trying to cure patients that were told that cure for them was not really a possibility. And for each of the members from the Ministry of Health team, we were trying to match a team member from the NGO in a way that they work in a complementary way. So not really competing for doing the same activities, trying to help each other. Sometimes the health workers cannot leave the health center, but somebody has to be doing that work outside the health center premises. And in that matter, the members of the community were really helpful. And we learned also that in order to make a good treatment, a good regimen for the patient, we need to document very well what kind of drug resistance we have in the country, and we didn't have the technology available during that time. So we have to establish a partnership with Mass State Lab Institute, where they were kind enough to help us to document large number of samples with drug resistant to first and the second line drugs. But this process, they were also committed to teach the Peruvians, so they can start learning, and the Peruvians also get the equipment and the tools to start doing that on their own. So right now there is no more need for Mass State Lab to get involved in that activity. So the colleagues at the lab, they can take this responsibility very easily. And it was mentioned, in the previous session as well, how challenging it's to take, political decisions when you have a long turnover of officers responsible of any particular program. And here, you have during the 90s that you have a director that was in that position for about a decade, and that certainly helps to run a very strong program and you set up policies for the country. But as you can see in the following years, the stability in terms of leadership was really challenging. But for me, it was a very good learning experience. So it's like every time I have a new national TV program director, was a new opportunity to deal with a big shot in terms of what should be the next steps for treating MDR-TB in my country. And in this slide, you can see that the number of patients that were enrolled, 96, 97, 99, was really low. But the point I want to make here is that during those years, the number of cases with multi-drug resistant tuberculosis was not there. So when it was mentioned that sometimes on public health there are a lot of cadavers, so I think that during those years there were a lot of true cadavers, and we were not really treating properly a lot of MDR-TB cases in the country because we didn't have the resources. We have to start treating the ones that we knew, and for the ones that we have the treatment available, the drugs, the medicine. But it was really painful to see that others have the disease, but we were not able to provide a treatment because it was really expensive. But the situation started changing around 2001 when we got the funding coming from Bill and Melinda Gates Foundation, and then the Global Fund mechanism allow us to start enrolling more patients. So in the process of treating this large number of MDR-TB patients in Peru, we were always focused on the patient and the family. They were the center of our intervention. We have to pay attention on the clinical care, social economic support, and psycho-emotional support, having staff coming from the Ministry of Health, from the community, and from the NGO. But I know that I shouldn't be talking much about the clinical care, but I just want to emphasize that this story in my country, moving from one regimen to another, it was an unnecessary delay of treating properly an MDR-TB patient. So this is a story also with bad ideas that didn't work well. It's not that we were supporting these ideas, this kind of regimen. We were trying to get the right regimen for the patient at the right time, but it took so long and shouldn't be so long in other countries. As you can see, when you are doing an evaluation, you have 40% cure smear conversion when you are at month 6 on treatment, showing you that you are not in the right regimen. But in 2005, when finally the government realized that the best way to treat an MDR-TB patient is as soon as the patient is diagnosed, you have a 94 smear conversion, which puts you in a much better scenario to treat patients. And just to give you an example of the meaning of having a very well committed group of community members to understand all the process. So when they saw this record of smear and culture, you have a red cross showing that it's positive, and you have a black mark that shows that everything is okay, going negative. So for them, for the community health workers, learning about the importance of understanding what was happening, so they have an opportunity during the nighttime to explain with more detail to the patient how the treatment was going when they were at home, and instead of having a very brief and in a hurry meeting with the doctor every month, just 3 minutes or 5. It was an opportunity for the health promoter to explain every night that everything was going well, and if for some reason was not going well, to start discussing the different options about making the changes. And it was also a good opportunity for us to start implementing new technologies for the care of the TB patient. So now the National TB Program have a electronic medical record that captures the information anywhere in the country, and they can read it anywhere, and the doctor can provide a good follow-up. And that was really a very good contribution. And now, learning about the social economic support that the patient needed, we learned that it's not just about the patient. If there is a patient with MDR-TB, there is a family suffering there, and there is a community at risk. And when we say the community, we are also including the medical, the health staff that is taking care of the patient. But in terms of what could be possibly provide to these kind of patients, so we learned that if we want to treat a patient coming from the countryside, they may need a place to live in the big cities, or they may need to improve the house where they are living because of the overcrowding condition. And if you can get somebody interested in making a donation of a house with a proper ventilation and that allow more space for the patient to spend the night alone and not exposing other members of the family, that will be a tremendous addition to a comprehensive approach. And certainly nobody wants to take 10, 20 pills that are really painful in an empty stomach. And you have to find ways to provide food to the patient as well. And the Peruvian government was providing food basket for 6 months, but the treatment was 24. So you have to find ways to provide that support during the whole process of the treatment. And somebody may say, why you have, if you are limited in your budget, why you have to spend money on recreational activities? Why you have to celebrate Christmas with them? Why you have to celebrate Mother's Day? Why you have to celebrate Independence Day? That's probably a good question, but what we found is that if you have somebody receiving treatment for 2-3 years, and every month that patient goes to the clinic, the doctor say, I'm sorry, your lab results still show that it's positive. It's bad news. So after receiving 2 years of bad news, finally you got in the right treatment, and in the month 2 or in the month 4, for the first time you become negative. That's really a reason for a small celebration. And usually it was a dinner between the patient and the health promoter, having a good dinner and discussing that, okay, now we are in the right track, let's keep doing for the rest of the treatment. And that was really encouraging for the family as well. And I hope that you realize that for families living in poor settings, moving from the house to the health center takes time. And walking, and they have trouble with the lungs. They cannot walk long distance, so they need to use public transport or small transport as this motorbike that you see there. So providing that additional support means a lot to them in terms of receiving the treatment on time and not really suffering unnecessarily for walking long distance. But you probably also are aware that in most of the countries around the world, you heard that the treatment is free. Yes, we provide TB treatment, and they don't have to pay a bill. But even though the treatment is free, sometimes there are some lab tests or medical procedures that are not covered by the insurance program from the government, and you have to make the investment if you have to make the proper follow-up of your patient, and certainly that was really challenging, and we were documenting everything that was needed to document, because the staff was trained from the beginning that they have to be accountable for anything that they will be asked to do, and certainly not everything was really, not all the time was really good news for the patient. Sometimes they have doubts in terms of what's going to be the outcome on this treatment. Some of them even wants to commit suicide. So you have to start also paying attention to what was bothering them when they were before they want to start the treatment or while they were on treatment. And you have to think about ways to provide that support, sometimes in an informal way, others in a more formal way. And the creation of the therapy groups really was key. And in these therapy groups, a former patient attend the sessions and provide the explanation to the group of patients that were having doubts in terms of continuing the treatment or not. And and as a result of documenting everything that was happening, here you're looking at the abandon rates. So here you're looking at patients going to the same health center, but one of them receiving the standardized treatment regimen, who was really providing very low cure rate, and a group of patients going to the same health center, receiving the individualized treatment regimen tailored to that drug resistance that they were having, and receiving in addition the social economic support, the presence of the community health workers, but the ones receiving the standardized treatment regimen, they were just receiving the drugs. And the increase of the abandon rate was really important, but when we have all the package in place for the patient, the number of abandon rate was half. And that was, even though this was not set up as a formal study, but having this kind of information available for policymakers allows us as Peruvians to have more support coming from the Global Fund to get money to provide, food basket, transport, and help other patients to cope with the treatment. And just very briefly, so you can have an idea, here we are talking about treating patients not just in one big hospital. We started with 5 health centers and 21 by 99, and then in 2005 we have to deliver this treatment in 280 health centers in the Lima metropolitan area, and start also scaling up to other places in the country. So every place, moving from one health center to another, was a new opportunity for the team led by the nurses to start implementing the strategy in a way that we bring more partners on board to this big crusade. And certainly it will be impossible to keep enrolling patients at the cost that we started the treatment. When we start treating Paulina, the cost of capromycin was $30 per vial. So making a regimen that required an injectable for 8-10 months at that cost was really difficult to get more on treatment. But the green light mechanism, was able to reduce the cost of the drug. The capromycin dropped to 99 cents of dollar. That allows to treat more patients, and show us that that the cost that we are facing at the start of any project is not necessarily going to be the same if we don't start pushing for more affordable costs for making this strategy work. Right now, this mechanism has a large set of partners, and everybody now is committed to provide more treatments around the world, providing the technical assistance that the countries need to treat TB patients, and certainly with costs that are more affordable. And the work that Socios en Salud started from the beginning was not really with the intention that Socios will take the responsibility forever. So we established a partnership from the beginning with the government, so they can start learning from the start. All the different elements of the strategy. And we were also thinking that the model works very well with MDR-TB patients, but what about HIV patients? 1% of our patients were co-infected with HIV. And once we learned that HIV treatment was also available for free, we want to develop a strategy where, using community health workers, we have an opportunity to enroll more patients, to have a health promoter also helping them, and then transfer to the responsibility to the supporter. Everything in a period of 2 years, and then it's going to be just the patient and the supporter. Supported identify from the close contacts of the patient, and it's working well. But what else? So as I tried to mention from the beginning, this was not just treating MDR-TB patients was not just about good regimens. So we knew that we were fighting against poverty, and there was no point to treating just with medicine and not start thinking about what are they going to be doing once they were declared cured. So we were piloting different initiatives in a way that how can we how can we set up, for example, a microfinance project where the patient can have, an opportunity to run a successful small business. So by the time that they are cured, they can certainly start doing their own business. And here you can see, maybe nothing impressive, but I think what we were able to show is that even in those resource poor settings, we were able to bring some hope, and they can take from there to not just cope with the treatment, but also try to raise the family without much burden. And the preliminary result that we have with this group were also applied to different groups in different settings with the same outcome. But I have to say that we are not really there in a way that we are scaling up those initiatives. But I think that it's good to have documented what was working well, and maybe somebody take the next step. And as mentioned before, establishing the partnership, with the government was key. But then, trying to establish or trying to get involved with others on the international level was really interesting, because we knew that this experience was not just about the Peruvian patients. So this was something that will have implications for patients all around the world, and all the ones who were skeptical needs to bring on board. So they have to see firsthand what was happening in Peru. They were always welcome to visit the patient. They were always welcome to come to the clinic, welcome to go to the houses of the patient, welcome to review all the data in the electronic medical record or at the hospital. So they can see that what was happening there was really real. And more importantly, that in this process, it was not just all international funding coming up, because in the national TB program budget during the 90s was about $3 million, and then by 2008, $10 million, and right now it's $33 million, and includes all the package that I was describing previously. So right now, we started the experience with funding coming mostly from international donors, but right now, 100% of the activities to control TB are coming from the government. And another, interesting learning experience that I had is that, investing in locals. So you are looking at Eda. Eda lives in Caraballo. She was a nurse student, and she was leading the team. She was invited to come to Virginia University for a semester to share the experience with colleagues here, and you are looking at Flor. She started working as supervising the treatment. Now she's a computer engineer, and I just can keep going, showing you examples of, what's the value in terms of investing in local human resources. So they are the ones who remain. You can change politicians, you can change, NTP managers all the time, but they are the ones who remain in the community. So they are the ones who will be always thinking about the next problem and how they will be solving the problem in the future. And also, it was a very interesting opportunity for trying to implement different business opportunities. So, as you can probably imagine, you have to deliver, a food basket every month to 2,000 patients in a city of 4 million, or actually 7 million inhabitants. It's not really easy. Okay, we have the health center to deliver the treatment, but how do you deliver food basket? How do you run that chain of support? And what you're looking at now is a group of community members who are running a bakery and a small market in one of the poorest neighborhood of Lima, and they took the responsibility. And, the easy option was, okay, you have a coupon and you can go to a big market. That's one option, and that's fine. And there is nothing wrong with that. But you have also the alternative. You have also the option to give the chance to them to run a new business, new idea, and keep the solidarity going on, and keep expanding that in a way that, everybody wins. They have a job, they have a business, and they are providing a good service. And similar situation when we were trying to move the patient from the house when they have an emergency to the hospital. I actually called all the ambulance services in Lima. Nobody said, yes, we can do the service. As soon as I said that it was a TB patient, I'm sorry, we are too busy. No, we don't have. Nobody wants to provide that kind of service. So it's like we have to get back again to the community and ask them, we have this trouble. Can you find a way so you can get organized a group of cab drivers? So when we have any emergency, you can just go to the patient and bring it to the emergency room. And a group of 20 sign up and they run a business that allows the transportation for the staff working at the NGO, for the Ministry of Health, and for the patient as well. And when we were asking the journalists in the country, why don't you talk about the TB situation in the country? Why every time the Ministry of Health sends you a press release, you don't write something about it? And we have to pay attention about what they were saying. They said every time you send a press release is coming up of the facts, we just grab it and put it to the trash. We are not. We are journalists. We are not supporting the government. So we are journalists. We need stories. If you have a story, okay, we pay attention. So the way that we find one way that we thought that it will be interesting is that we launch an exhibition where we have posters from all around the world that shows the history of tuberculosis. The first way that it was discovered, and from theater, from musicians, everything that was about TB was presented in a show. And we have one patient that was an artist, and he was doing an exhibition while the big one was in place. And then the journalists were curious about what he was doing and why he was doing. And and having that face, having that story triggered their attention, and we have more opportunities to get more awareness, get more funding. And then, for example, the cow parade, probably you are familiar with that. It became to Lima, and then when we got more awareness on that, we have money to start treating children with HIV. So now we can say that we have more than 60 countries around the world treating MDR-TB, but I'm not happy to say that we have the problem under control. We have an estimated number of 500,000 cases every year, new MDR-TB cases, but we are treating only 10% of those. So only 50,000 cases of MDR-TB treatment are on proper care, but the others we are not doing a very good job still. And that situation needs to be fixed, especially knowing that there is a growing concern in terms of resistance become more complicated to treat, and XDR-TB cases it's in the news, and even totally drug-resistant cases are on the news. But I started the story with Paulina, and I thought that when it comes to the time to make a very strong position with the government, here you're looking at Paulina addressing at the Congress in my country, and she was part of the presenters that were defending the strategic plan for the next decade. So when I say that now we have $33 million for treating TB in the country, was after this kind of intervention, whatever I say may be good or not. But when the politicians start listening, the patients and the journalists start paying attention about these kind of stories, you can have a more receptive audience. And when this picture is in April last year with Dr. Kim in Caraballo, and Paulina wants to tell him that now she is very close to finish her training as a nurse technician, and she wants to get back to work. She wants to get to complete her training and get back to work at the hospital where she received the treatment. It's going to be the best way for her to acknowledge all the support that she got from the staff working there. And here you're looking at Percy. So, Percy is doing very well, growing up very fast. And also the lesson that we are getting from this story about Paulina is that treating MDR-TB patients, even though was really complicated, it was possible through a very large group of committed from different disciplines, from different institutions. But what was important to have from the beginning was a strong commitment from the community. They believed that this was the right thing to do. And they believed that this was not just for a small group of patients, that everybody that was diagnosed needs to receive the same care that was available anywhere in the world. And this was a long journey. And again, this is not done. This is still needs to continue the fight. But I'm very optimistic that the next steps that are coming up will be possible to establish with larger partnerships. Certainly, I didn't want to finish acknowledging all the support that the community health workers gave to this work. Thank you very much for your attention.
Jaime, thank you. Just absolutely fascinating. I think, what I take away from it is, how creating sustainable community-based solutions are important for sustained positive outcomes. And bringing in this, multi-stakeholder coalition, you went to the politicians, the media, and the community. And then also taking a very integrative approach in terms of psychological and economic approach. So absolutely impressed. I would now like to invite Nicole to give her comments and thoughts on this. Thank you.
Thank you so much, and thank you so much to Jaime Bayona for this phenomenal presentation and success of a real development story. When we talked yesterday, you told me also that you were actually one of these young physicians in the rural areas. Not too many physicians came to you because maybe you were one of the first ones and they were wondering what on earth you were doing there. So you did some outreach, and I know that you helped the community, the women in the community, get better quality sweaters to sell at a better price, to earn a better income. And so you are actually a development worker and not a health worker. And I just would like to acknowledge that from the beginning. What am I taking away? First of all, it's a really great presentation. So I understand that Jim Kim and Paul Farmer were young one day, and so they look much younger on these pictures. They had a lot of passion, energy, stamina, patience, perseverance. You mentioned the word crusade, and I think this is not a health crusade. This is a development crusade for development outcomes, which resonates a lot with me. Then, as we all know, health outcomes are not determined by health sector interventions only. They are determined by many different sector interventions, and are very crucial, sometimes even more crucial than building a new clinic. Could be to deal with water and sanitation issues, or with many other difficult problems that strike the community. So community involvement, that's what I'm learning, and that's what I'm taking. My takeaway is community involvement, taking a broader approach to development, even if it comes from one specific sector, issue of this treatment. And if I may say so, the TB, the multi-drug resistant TB treatment, basically made it clear, and the success of it, that you can actually tackle service delivery issues, that you can actually come to results. So when the HIV epidemic was really rampant and everybody started understanding that it is rampant, that was actually easier to treat. In TB, you needed a regimen, and actually a friend of mine does have TB, and she takes the 10 pills every morning, and she has to have this special juice to digest, and she is sick, and she gets nauseous, and actually she works with me. So we do need to take care of when we can see results. So we can see in the HIV/AIDS epidemic that actually service delivery in chronic diseases is possible, even though we believe that they are communicable diseases at the beginning, but then turn into chronic diseases. So it gives a lot of hope, and to understand that actually we are able to develop health systems that can deliver quality services, even for chronic diseases, now that we're talking a lot about non-communicable diseases and treatment of diabetes and cancers and other diseases. But it's not a health sector intervention alone, and that I think is really, really important to always keep in mind, and I think you have very open ears here at the bank talking about that. If we think of and Tamara was talking about the universal health coverage agenda, and the drive of the two goals of universal health coverage. If you want financial protection, so we want to make sure that people don't fall into poverty due to a health shock and an expenditure shock. And that expenditure shock can come from the treatment, but also from the transportation or from the loss of income. So the integration and the discussion around social safety nets are really important in that setting. When we talk then about the service delivery angle and to make sure that affordable services are available of quality, that's where your experience in Peru is really provides very valuable lessons for all of us. And to see, so you want to strive for results and not just for the inputs. You want to bring the coalition building. You want to bring the participation. You want to have the stakeholders engaged, because people need to believe in the results. And when people believe in results and they can be demonstrated, the Minister of Finance will also open the purse. And it's not just a begging call to the Minister of Finance to saying, like, we just need more money. But so it's a whole chain of events that need to happen, and we need to work on all of them at the same time. I don't think it's a nice linear approach to success. I think it's messy, it's chaotic, and it needs a lot of patience and stamina. So thank you very much for your excellent presentation.
Nicole, many thanks for very incisive remarks. And I think it puts it very nicely in the context of development, and not just health, but other areas for us. So with that, I'm going to open it up to questions. Maria Luisa, I wanted to know, I know that people are watching this on Adobe Connect. Are we getting questions from them, or that's not? Web streamed, okay. Okay, so then the questions are for the floor then. Yeah.
I don't know if it's a comment or a question, but I just wanted to really fully endorse a couple of points that have been made, and that is multisectorality, integration, and integrated approach. Now, looking at this from an HD perspective, where we have the three subsectors, I think the example of Peru clearly highlights, among other things, the very strong relationship between health interventions and social protection. And I completely agree that in many cases, interventions that are sector-specific, be it health or education, the factors that contribute to problems are really external to the sector. So it is just, I think, from my perspective, is to fully agree with what has been said, that, we should really, if we are focusing on health, we should perhaps also give equal importance to looking at other sectors, such as social protection or education or agriculture, for that matter. But the question in here is that it's one thing to say that, and the political will and leadership is also another thing to see. In the context of Peru, when Jaime was talking about, okay, at some point, okay, there was a health intervention, and then there was this sort of income-generating micro project, and then later on, I guess, from politically and institutionally, people come to support that from various sectors. I would be very interested to know, like, what is it that would help inspire sort of a more integrated political leadership, multi-sectoral political leadership that could help leverage support for a more, holistic approach actually to human development at the core. Thank you.
I think that the political will in the country over these last 15 years has been changing over time, and we have to be very consistent in terms of telling the story one time after another, but trying to be very consistent that it was not about just a health intervention, that this required a more broader commitment from the community, from the different organizations that was trying to support the government. And I think that with the Global Fund mechanism, we had the opportunity to create one body that was overseeing the projects or the interventions around TB, malaria, and AIDS. And in that, it's like create a forum for have a official representation of the different constituencies. But it was the first time where the representative of the patient have an official voice, and that I think that makes a big difference in terms of what probably the politicians wants to do, but without listening what the patients wants to say was really not an easy decision for them. The media start also paying attention what was happening and make pressure in terms of the changes that that needs to be implemented in the country. And I think the story that we have here, it's something that could be easily applied to other other chronic diseases. Right now I know that in my country there is a need for providing universal access to cancer prevention and treatment, and I think that that's a very good initiative. But I'm feeling like the key component of this intervention, the involvement of the community, it's something that has not been presented very well yet. So it's like we don't have. I'm not saying that it's not going to be possible to show it. It's like we failed to present it, but the data is there. So if somebody wants to work and get a study that shows the value of the involvement of community health workers, I'm pretty sure that it will come up with very strong data that will support and may allow politicians to start considering that intervention for other chronic diseases. But that's not in place yet, and that's probably something that needs to be working in a different way. But when I had the opportunity to travel to other countries, after the experience in Peru, I was invited to other programs around the world and telling the same story. And when I was traveling, I was not planning to get involved in a discussion about the treatment, because that was something that probably someone else can do better than me. But when it comes to the point of why we have to start making an investment in social economic support, that was really not easy to sell. But showing one in more than one way, what we were getting in Peru, what they were missing when somebody was abandoned the treatment, what was the consequences of having investing $25,000 in a treatment, and then suddenly, losing that because that person was not, adhered to the treatment, and the implication of having somebody failing a treatment with more family members in the house at risk to get the infection. I think that's when they start, paying attention. And I want to mention very briefly that I was very pleased to see that, for example, countries like Ecuador. So they learn about the experience in Peru, and they realize that they may have other ways to provide the social economic support that the patient needed, and they decided to give the equivalent of the minimum salary to all the MDR-TB patients. So it's $240. That if the patient received the treatment every day, at the end of the month, they receive $240. And right now, there is just a preliminary evaluation. So before they were implementing this strategy, the abandon rate was 31%. Right now, and this is just preliminary data, is 9%. And with a big chance to keep reducing that abandon rate. So, but again, in trying to be very creative in terms of how we engage more partners on this, but at the same time documenting what we are doing. At some point, what we were doing in Peru, it was happening so fast that we were just documenting and keep recording, but not really spending the time to analyze what we did, because this was not set up as a research. It was not the intention. There was no need to do research when you know that that treatment is working in other countries. If it is working in another country, there is no reason why it shouldn't be working in countries like Peru.
Yeah, it was basically, the question is probably also addressed in the bank, when will we break down the silos? I think that's the question, really. And yes, it is hard, because we have been set up like the governments in different sectors and in different silos and different compartments. And if we just could take a look at health outcomes, or a product of many different inputs into the production function, if you want, of that product. And there you can see that I'm an economist and not a health person. So the issue is really around incentives, and if we can create in countries the incentives for working together and for seeing and for understanding that this works, there are very obvious interlinkages. Those discussions are easier at the local level than having them in a state capital. Because in a state capital, everybody fights for the budget and fights for resources. It's like in Washington, D.C., in HQ at the World Bank, everybody fights for resources and for staff. But if we can come together and understand that there is something bigger that is called a health outcome, and it's about healthy people living in a healthy planet, if you want. So if we want to increase healthy life expectancy, we're going to have to all work together. And we need to start having these discussions. The public health community group started having these discussions. There's a lot of discussions with mayors in Latin America around the tobacco control. There's a lot around transport, urbanization. I know you worked on urbanization and what that means for delivery systems as well. So I think we really need to keep the focus not on the sector input, but on where we want to go and what the result at the end of the day is. If we can have conversations around this with multiple stakeholders, politicians, journalists, media, civil society groups. I know we are not specialized. We're getting much better in the last, I've been here 18 years, so we've been so much better now in talking to civil society. When I came 18 years ago, we were not talking to civil society. We were being thrown tomatoes at us from civil society, and then we started changing that dialogue and understand that we need to have a conversation. So if we can convince ourselves and our counterparts to have these discussions, it's good to have the conversations and not lose the focus on what is actually the result we want to get at. And then finding the solutions. We cannot, as Al said, we cannot export the Peruvian experience. I'm going to now be brutal into my country, that's Switzerland. We cannot do that. We need to look at local adaptation. We need to see people in these countries know best what they need and what works, and then we can just bring inputs and kind of be the convener of conversations and make sure that there is engagement. We're not going to be the neo-colonialists who
bring down, this is good prescription for you. I know we have the tendency, but it's really important we don't do that we engage at the country level. These people in countries, never worked for 18 years with people in countries, they know what is best. Sometimes it's just good to have some other ideas or input. And so the knowledge exchange, and that's what I think what we're trying to do today, and this is really also the mission of WBI, which I really commend very highly, is to have this knowledge exchange with different partners. And today we have it with Dartmouth, and we're learning from Peru. But it's so important to just really get rid of our biases, if you want, because at HT, so that's the Human Development Forum, is a big learning event. We heard a lot about biases and how our brains work. If we can really think about getting rid of our biases and be open to new idea and creativity, and listen to countries and their and where they want to go, and they want to go with their policies, then we can maybe really be able to support across all the sectors that matter for development, to achieve better health outcomes for healthy people living on a healthy planet.
Excellent, Nicole. You were brutal, but you were very right in terms of how we work in silos and how we think that everything has to be just streamlined in that way, and we don't look beyond, and we don't look for multi-stakeholder involvement. Any other questions? Okay, so I'm going to go. We'll take 3 questions, so 1, 2, and 3. Did Ed have a question too? Ed, did you? No.
Thank you, Dr. Jaime. I think that's really interesting and really inspiring story. One lesson I learned is that you really create a business model which creates a win-win situation, such as taxi drivers as well as a group of the lady who provide the food. However, in many developing countries I worked with, I know the community leaders, they provide a vital role. And sometimes when the leader is gone or, other reasons, suddenly the system just, cannot be sustained. Mm-hmm. So I wonder, in your experience, how do you think that such program can be sustained without too much rely on particular leaders?
I'm going to take the questions in a group.
Okay.
Hi. I have a very practical, sort of pragmatic question. You mentioned that you combine the different economic and social and healthcare aspects to deliver an integrated way of assistance. And then you also mentioned that because part of the funding was for CFATM, you were the Global Fund. Mm-hmm. You were treating TB and AIDS and malaria. Now, what if you had a patient who had some other conditions? How far did you go out of your way to get them treated? Because, from the patient's point of view, this would be very important, and all the TB treatment money could also be wasted if they have some other conditions. And how did you do that, if you did do that?
Okay.
Hi, my name is Andrew Zakarenko. I want first to thank you for this case, for bringing this case to our attention, because I think it's very important as a model. And first of all, because every life counts. And secondly, also because you work in my home country. Thank you for this and saving those few kids with these non-traditional diseases. And second point is that I also feel synergies because I come from the different sector. We work on saving wild animals. And we find that the non-traditional models like this, when you work on something different, but you create these non-traditional coalitions, you invest into the political will, you invest into sharing the knowledge between non-traditional partners and involving different sectors, it pays off for traditional approaches. As you said, you've got 3 times fold increase in the national budget allocations. You've got such a huge public awareness. You've got communities working for you. And this is wonderful because it shows your experience as a model which works and which finds synergies in different sectors and which can be scaled up. Thank you.
Okay, thank you. Yeah. I think that the ideas with the business model, I have to confess that everything that I discuss with my local coworkers was started with, we were trying to solve the problem. So it's like this is the problem that we are facing, what we can do. And it was after the discussion when the possibility comes, so what if we create a small group of drivers that can get organized and take this responsibility. And they started with a small number, 5, and then start growing up because we have so many patients there. But they learn that if they get organized, they can receive phone calls from others. Organization or others that wants to have a service, even though it's in Caraballo, it's very far from downtown. So I think that over time they had the opportunity to learn how to run business. This is not something that I can certainly teach them, but it just try to motivate them and get into the opportunities that the government provide to anybody who wants to run a small micro enterprises. So it's like they have an opportunity to do something, but at the same time the government was there to provide the tools that they need to run a very successful business. I want to mention as well that there was a group of patients that was that get organized, and they were providing services like cleaning offices or doing maintenance of buildings. And the first customer at the beginning was the offices of Socios en Salud, but very soon others started to realize that what they were doing was really good, working well, and they started inviting them. And another, idea that they had is that because of this global fund opportunity, there was a long list of training activities going on, and somebody needs to provide catering for those activities, and they asked for the opportunity to take that responsibility. So they start providing the coffee breaks, or the lunch, and certainly the quality of the work is the one that guarantee that you get called for the next time. It's not that you are recommended by somebody, and if you are not doing a very good job, you are not going to receive a second call for the same service. So they start working with us, and they were the ones who provide all the catering when we have international meetings, and very soon the Ministry of Health also wants them to provide the same catering service at the Ministry of Health headquarters. And then the regional office start liking the idea, and I know that right now they are still going on business. I don't know if they are really in a massive scale intervention, but that's probably something that needs additional coaching that I don't have, or others from health sector don't know how to do it. But I think that what we can learn is that once you launch a very good idea and is working well, you have an opportunity to keep building into that idea and try to make it successful in the long run. And again, all these activities have a very good, very well motivated leaders, not leaders at the NGO, leaders in that group who take the responsibility to make it, survive in the
conference is about to end.
With regards of what we do when we have a patient and they have, for example, diabetes, or when they have another health condition, we sometimes were limited by the budget. But that was really, if we have budget constraints, we know what we have to do. And, we have to take care of whatever medical condition that the patient have, or whatever condition was bothering the patient at that point. We have to be very creative in terms of helping them to solve those problems, because if they have that concern, they will not be able to complete the treatment in a successful way. So if we have to provide treatment, additional treatment for surgery, we have to get the funds to do that. We have to start talking with a different hospital. How can we get a discount? We never were working under a scenario where we have plenty of money to sign a check and just do it. We were always in a situation where we were with very limited budget, and we have to start doing less activities in order to assure that that patient will have the surgery that needs for be in a much better health condition. So we always try to by default, we always try to treat, the patient with all the problems, that health problems or non-health related problems that were bothering the patient. And